want to remind our audience that many of our presenters are new to Second Life, so please be patient with them. Hold your thoughts and questions until they're done presenting so that they can concentrate. Thank you, and have a good day. And Bonnie was supposed to introduce our first speaker, but I don't see her here, so I am going to take the opportunity to introduce our first speaker, and that would be Karen Fortuna. So Dr. Fortuna is an Assistant Professor of Psychiatry at Dartmouth College in Massachusetts, I believe, and she is also the co-founder of the Collaborative Design for Recovery and Health, and I think she's going to tell us about that today. As an international collaborative of patients, peer support specialists, caregivers, policymakers, and payer systems, the collaborative uses community-based participatory research to facilitate the development, evaluation, and implementation of digital tools that leverage mobile health to address needs that are identified by community members from the vulnerable populations. And she's included the URL of her organization right there. It needs an HTTPS in front of it. Dr. Fortuna is co-chair of the Patient Engagement National Advisory Council to PCORI, and we've worked with PCORI before in virtual ability. She is currently co-leading a project to update the community engagement standards at PCORI and integrate those updates into their engagement matrix. The title of her speech today is Building and Sustaining a Digital Mental Health Ecosystem of Equity. And now I am done. And Karen, it is your turn. I would like to remind the audience to click on the giver box that is up front. That would be a good way for you to get some of the references that Dr. Fortuna is going to be talking about today.
Thank you, everyone, for joining me today. This is very exciting to be here and to share the work of the Collaborative Design for Recovery and Health. Today I'm going to talk about how we can build a digital mental health ecosystem of equity, meaning that everyone has the opportunity to engage in digital technologies, such as programs like Second Life. So just so folks know, I do have some disclosures. I offer consulting services through social wellness. Our team, which you'll hear about, has grant support to develop a series of technologies in which we're funded by programs such as the National Institutes of Health, PCORI, which is Patient-Centered Outcome Research Institute, the Japan Agency for Medical Research and Development, also the New York Academy of Sciences. Recently, we were funded by the American Federation for Aging Research, and then also we've done some work with the Brain and Behavior Foundation as well. So just for the agenda, what I'm going to talk about today is, well, what are the disparities in actually getting access to technology? And then I'm going to talk about what happens when we partner with people to develop certain types of technologies. And then I'm going to do a case example, which has been some of our work in which we have a partnership with individuals across the world who have a diagnosis of a serious mental illness. So that would be a diagnosis of schizophrenia, spectrum disorder, bipolar disorder, and major depressive disorder. And we're going to talk about one of the technologies we've developed as a team. and then current projects and future opportunities as well. And then, of course, we'll have some time for questions and answers. So, technology, it is ubiquitous, meaning that, yeah, we see it all over. But does everyone have equal access to actually engage in technologies? And so for today, I'm going to talk about mobile health, or M-Health. And so this is mobile phones, monitoring devices, personal digital assistants, or other types of wireless devices. And we'll talk about biosensors as well. So we know that this is a promising approach to support people with mental health challenges outside of clinical environments. So actually in the community when people need the services, in which maybe they don't have to schedule an appointment. So here we can overcome barriers around linguistics, literacy. We can access technologies in places like sub-Saharan Africa that may not have a mental health workforce available to them. Within technology, we do see improvements in M-Health around things, improvement around things like symptoms, recovery, psychoeducation, and supporting other individuals. And I'm going to talk about how we can get people access in places where we maybe don't have access. So let me tell you about the collaborative design for recovery in health. So here, studies have shown that digital interventions targeting feelings of harming oneself, they indicate a significant reduction in suicide ideation. And we know with the pandemic as well that due to the lockdown measures, a lot more people are using different types of technologies. So the use of M-Health has the potential to care for patients throughout the pandemic and actually beyond as well. But some groups may feel the benefit despite this high need for mental health services. So places in rural areas, people who are underserved, which may be Black, Indigenous, or people of color, or other types of individuals as well who may have disabilities too. So what can we do to promote the equity of access for these technologies? So let me tell you about the work that we do, which I'm so happy to be sharing with individuals. So here is our process, and I'll tell you about our 40-person team that's all over the country. Our process here is that in 2018, a colleague of mine and myself, and we decided to engage in the development of the collaborative design for recovery and health to make sure everyone has equal access to the benefits of mobile technology. And so here we are an international coalition of patients representing diverse disease states. It could be rare disease, it could be autoimmune disease, mental health, physical health, also clinicians who may have lived experiences of these diseases as well, or challenges around mental health or even substance use. Also peer support specialists who are people who have a diagnosis of a mental health challenge and they're trained and accredited to provide support services. Caregivers, parents, we work with industry partners, as well as scientists. And all these individuals may have a lived experience of one of these challenges. And of course, policymakers and very large payer systems as well. Here, we focus on co-producing technologies. And we focus on co-producing technologies, and in this process, individuals we partner with, they are part of the defining what the problem is that they want to address in their community. They work alongside us as equal partners with shared decision-making authority to develop these different types of technologies. We do the research together, and then we publish together, we present together, we travel the world together and present. And it's a really amazing approach. And know this, when we actually use this approach, which is called community-based participatory research, you get higher levels of engagement in the technology among the population you're working with. This is incredibly important because many people disengage from technology after 2 weeks. Well, here are the secret sauces: partnering with individuals to find out what their needs are, what their values are, and developing the technology with them so then they are able to have access to this. So we are a coalition representing multiple different populations that we work with. We work with people with a diagnosis of serious mental illness, that's what SMI is, peer support specialists, older adults, Native American tribes, caregivers of people with dementia, and low-income countries as well. We represent multiple countries and multiple states as well. And so here's how it works. What happens is an individual will reach out to us. They'll go to our website and they'll reach out to us and they say, well, I have this problem in my community I want to address. And we're like, okay, this is great. This is a very important problem that we're going to help you work together to address. And so then we create work groups of scientists who are trained in community-based participatory research, and then we have them partner with the people, the community on the ground, and together there's dyads, so they work together to develop solutions to the challenges that the individuals are facing. And I'm going to talk about one of our projects around early mortality in people with a diagnosis of a serious mental illness. And so this is our didactic training that we offer. So it's not only patients or service users who are actually trained in the scientific method, it's also scientists who are trained in community-based participatory research. So here is the whole team, and we offer trainings, resource sharing, seminars. We're also offering competitions as well. In that we have over 40 members representing these diverse population states, and together we represent multiple areas of science. So we have people who are physicists working with us, working with the social worker to develop biosensors, right? We have computer scientists working with people who experience a disability, and they're integrating machine learning into different types of technologies and apps that we're developing. And together we have over 100 peer-reviewed publications that are in the scientific literature. We have grant funding that supports our patient partners at equitable levels. Individuals even have equity in some of the technologies that we developed. And so it's a really exciting project that was spearheaded by this need to collaborate with individuals. So, okay, I can tell you, it's this great partnership, we're doing so many great things. Well, how can we make sure that that is actually accurate? And so here we've actually developed a tool to ensure that there is equity in the partnership, there is honesty, there is respect for our patient partners and people joining from other groups like policymakers or a scientist as well. And so here we have an accountability tool. So what normally happens is that people engage with the community, and at the end of a 3-year study, they do a survey to see how it went, right? Well, that doesn't give you an opportunity during the actual study to make modifications and changes. And so here, this tool, which was developed with our partners, we integrate it every month. to make sure that everyone feels respected, feels valued, feels prepared. And then we make modifications to our approach based on these types of things. And so this is really, really important if anyone has ever engaged in community-based participatory research before. So I'm going to share a case example of some of our work, and then I'm going to present some other ones as well. So here, within this, we're going to talk about our efforts to address early mortality with individuals diagnosed with a serious mental illness. So, just to give you some background. People with a diagnosis of a serious mental illness, they're affected by medical comorbidity, earlier onset of disease, and they die up to 32 years earlier than the general population. We have known this for more than a century in the scientific literature. And there have been all sorts of approaches to try to address this early mortality health disparity. This is not okay. A new paradigm must be developed, because if we've known about this for over a century and people now are dying younger than ever before, not due to COVID, but they're dying younger than ever before with people with a serious mental illness, something needs to happen. So let me tell you about what the scientific community has been doing. So here, the scientific community has co-located services, okay? So what that means is that they put in mental health centers, they put primary care services or physical health services, or if you go to a primary care, they put mental health services. And that's great. And so that could offset some of the, some of the transportation issues for individuals, actually accessing services for individuals. And so here, we found that the co-location of services, it actually may not be enough. And so, because when we looked at this, we learned that it did not impact these cardiometabolic outcomes of individuals. However, what we did see where some of the best outcomes were around these cardiometabolic outcomes are peer support in self-management, okay? And so here we have individuals with a diagnosis of a serious mental illness as they die 32 years earlier than the general population. It has been mainly attributed to different types of health behaviors. So diet, exercise, living a sedentary lifestyle. And the first approach was co-location of services. It may not be enough, but peer support and self-management hold promise for individuals. So we conducted a systematic review of the literature. And well, we looked at things like, well, okay, what's out there? So we found a whole bunch of self-management interventions. They teach people how to manage their mental health and physical health at the same time. And so within that, there's these great programs that are out there that have helped people and have impacted mental health and physical health. However, there's major implementation barriers. So these interventions are up to 1 year to 2 years long. Imagine having to physically go to a place once a week for 1 year or 2 years and actually receiving services. Well, that's a major barrier to care. And then there's also a highly trained workforce as well that is needed to provide these types of services. That is very costly and challenging to train. And so these are the barriers to this. And so we thought about, well, what if you combine peers, so people who have mental health challenges or a diagnosis of a serious mental illness themselves, and train them to provide services to others and use technology. So we can reach people in many locations and people don't have to worry about transportation to get to these places. Well, let's look at the evidence of peer support. Now, this is mental health peer support. All right. So here's the impact of digital peer support interventions. And so what we see is that is that peer support, it's been around for hundreds and hundreds of years. It was first written about in France in the 1800s or so. And this is the first actual document of peer support. And here it was patients who were discharged from the hospital, and they were supporting others in the community after they were discharged, and they saw improvements. And here we also see improvements of peer support around feelings of hope, quality of life, medical self-management, psychiatric self-management, health-related quality of life. So there's a lot of benefits to peer support. Well, now listen to this. What about peers actually using technology? Okay, so this is interesting because when we first proposed this to some brilliant scientists that we work with, and they were skeptical that a person with a diagnosis of a serious mental illness, if they could actually use technology. And so our team was like, of course they can use technology. It sounds like discrimination. And so we conducted a study. We asked peer support specialists from all over the world, do you use technology? And yes, 95% of them said yes, they do, and older adults as well. They use these types of technologies. So this is just one of our studies, and it was really a way to, show the scientific community that yes, this is something that individuals do offer and do use, and they're willing to use this as well. So let me tell you about this really cool technology that we developed, and this is called PeerTech. So PeerTech is an app that our team developed, and it has a patient-facing portion of the app, and then a peer support specialist version of the app as well. And people are able to communicate through text and through video too. The peer support specialists here, they are employed, they are paid, and they provide these services. They can put their hours in the app. We're working to integrate this with Human Resources Department so we can show how many hours people are using the app. And they can also add their own wellness plan on their side of the app. And then there's curriculum that they use around supporting people around mental health, physical health, and social health challenges, such as feelings of loneliness and feelings of hopelessness as well. And it helps guide them through this evidence-based curriculum. And here's how we actually developed the app with individuals. And the patient part of the app is that they can reach out to their assigned peer support specialist at any time if they are available. They can go through video, they can go through chat. They can also offer their own wellness plan. What are the things that they need to do every single day to make sure that they are well? And this is up to them. Maybe for one person it's going for a walk. Maybe for another person it's waking up in the morning and have a cup of coffee with loved ones. It could be a lot of different things, and it's personalized for the actual person. And then they have access to on-demand videos as well. And so with these on-demand videos, they can access these stories, these recovery narratives that other people are talking about. Yes, I have this diagnosis, but you know what? I'm living my life with this diagnosis, and it's possible. And we have seen scientifically that increases hope and feelings of belongingness for individuals. So in our process, we partnered with the community partners. We developed the technology, every single aspect to it. We have gone through multiple iterations of the actual technology. And here's how the patient population made it different than what a scientist in an ivory tower would develop. And so here they changed all of the language in that it was written at a 12th grade level. That could be really challenging for people to understand, no matter who they are. And so here we put the language at a 6th grade level, and then we eventually got it to a 4th grade level, and people found that very acceptable. We also added some design features which are aligned with evidence-based practices in that with the wireframes, there's a a two-layer architecture, meaning that it only goes forward once rather than going forward multiple times and having to scroll back. And that's just supportive of people who may have potential cognitive deficits. We also use single structure sentences, one idea, one topic per time. And what I really like about this is that we included things like trauma. How does trauma impact early mortality? This wasn't included in there, knowing that 90% of people who have an experience of a serious mental illness have experienced trauma. Why wasn't this included in there? And of course we added this. We also added things like, well, how do I deal with things like loneliness? How do I deal with challenges like grief? So we took it from the medical environment and really make it real world and what people were actually experiencing. So let me walk you through the classes that we've developed here. All right, so here we have a series of classes that we've developed. And so here individuals meet with one-on-one with one another, and they can meet in person or virtually with one another, and they go through these actual classes. So here it's the introduction to the smartphone, orientation, and recovery and health. What is recovery? What is health? Here, we actually train the peer support specialists to teach others how to use the technology. Then we talk about the impact of mental health, physical health, and our social health. All of them are interconnected. If we have a mental health challenge, that could exacerbate physical health conditions and also lead to challenges around social health. Then we talk about, well, recovery is a daily process. These are things that we need to do every single day to stay well. And it's okay to slip up. We have hard days. That is okay. And then we talk about how stress impacts our whole health. And this is around the stress vulnerability model. Has anyone ever noticed when they're extra stressed out, maybe they're a little shorter with loved ones, maybe they have extra aches and pains they haven't had before? Well, stress impacts our health, and so we teach people how to manage that stress. And then, of course, things around how do we live a healthy lifestyle, and so how we could make sure we exercise, make sure we diet or eat well, and healthy sleep and the importance of that for people. We also added information around dental health as well, which is really innovative because there's not a lot of programs for this population that focus on dental health. And then we have developing and maintaining relationships with individuals, and then how you get help from what you want in the community. So here is the technology. Here is how it works. On the left-hand side here, you see you have the peer support specialist-facing app, and on the right-hand side, you have the patient-facing app. Individuals are assigned to one another. They meet for 1 hour each week, in person or virtually. And in that, they offer this guided curriculum, which is based on evidence-based practices. And then we have a dashboard on top where I could see, or someone who's within an organization could see what people are engaging. They can assign service users, and we're working to integrate this with electronic health records as well. So we ran a study because this sounds great and all, but well, what does it actually do scientifically? So here's a single-arm pre-post study, and so what that means is that it's a small feasibility study. Like, let's see if we can actually do this. We had 8 people who were involved in the study. We were able to train the peer support specialists to use technology and take a look at their age ranges. These were all older adults. Everyone was able to use the technology, able to deliver the program. And then in our peer recruitment, we hired individuals who were certified older adult peer support specialists. Everyone is able to be recruited. And what we found from the information and the results is that it was feasible, it was acceptable, it does preliminary effectiveness around feelings of hope, increasing quality of life, increasing social support, led to an increase in medical self-efficacy, and mental health self-management and psychiatric self-management. as well. There we go. I think the slides are catching up to me. And so here we ran another study with 30 people. So here we this iterative design process, and here through this iterative design process, we ran another study with 30 individuals. They completed baseline and follow-up assessments during the study. Yes, we found it was feasible. Once again, we were able to hire people. We were able to improve our training as well, and we also saw results related to increasing feelings of empowerment, decreasing feelings of loneliness, and also increasing an individual's ability to manage mental health and physical health. So we have some really, really promising outcomes for individuals. All right. So here, how do we train people? How do we train people who may have potential cognitive deficits, who may be actively experiencing some symptoms around mental health and physical health? Well, this is really important because training isn't a one-stop shop in that there's a lecture, and within that lecture that we can take all that information and go out into the real world and implement this. Well, rather, it's people are trained, and they're trained over a period of 3 months. In that, we provide the training, and then people go out there in the real world and they practice. They go and practice, and then we provide support and feedback to individuals as well. And so here were the results. Again, I think I've moved a little bit ahead on the slides. So how do we create this mental health ecosystem of equity? How are we able to do that with individuals? And what does that actually mean? And so our team now, with all individuals, and in creating this ecosystem of equity, so I'm just getting the slides caught up with me. We provide equity of access to services, and so a few things that we can do, one of which is promoting digital literacy. And so knowing that, yes, people can learn how to use technology if they're trained, if they're taught. And we found that people who experience the same condition, potentially mental health, physical health, social health challenge, that it works really well to have a peer train another peer to actually use the actual technology. So promote digital literacy. Allow for other individuals to integrate and use the technology. In all of our studies, we don't require people know how to use the technology. We will train them, and we offer the support services to actually train people. And then we have embrace adaptive technology. So what this means, and for the people talking about access in rural areas, this is important, because what this means is that create technology that operates on no or a little Wi-Fi signal. And so here, there are technologies that operate on a very weak Wi-Fi signal, or they're even able to use without Wi-Fi. So something like WhatsApp, that's something that's used throughout the world and can be used in places with like sub-Saharan Africa that may not have Wi-Fi in those types of areas. And so we recommend including this adaptive technology within the technologies that we actually use. And this is creating the technology. Next, facilitate informed decision-making. And so what that means is that train people and support people in making decisions around using technology. Don't just prescribe an app to an individual, because that's what digital therapeutics can do. You can actually talk with the individual about what are their values, what are their principles, what are they interested in using certain types of technologies, and having a conversation with them. Because what if there's privacy issues in the technology, and this is really important to the person? Maybe they're taking the data and selling it to a third party. We'll have a conversation about that. And if the person doesn't want to use that particular technology, they can use another one. So that's what facilitating informed decision is about as well. and promote inclusivity in all of the mobile health design features, we can develop technology that's easy for people to use, no matter who they are, what experiences they've had in life. And so that's inclusivity. There are evidence-based design features that make it easier for people to use, and these are based on universal design principles, which is we include it in all of our technologies. And then, of course, reduce bias in machine learning analytics. This is a hot topic in that a lot of folks are integrating machine learning in their technology, and they may be using algorithms that have been developed with certain type of homogeneous population. So maybe it's using GPS addresses in a wealthy neighborhood that identifies with one race, and then generalizing that to the rest of the world. Well, we need to be really cautious about the bias in our actual machine learning. And then consider the participatory human-centered design life cycle. And within that life cycle is partnering with people who are experiencing the challenges and the issues in their life. And by partnering, we can develop something that has a higher level of uptake, will have higher effectiveness in actually being delivered in the actual program. And then here also facilitate access to this. And so here I'm training people around policies that are in place, because in the United States there's things like SafeLink or the State Assistive Technology Act or Assurance Wireless, all of which gives people free access to cell phones or smartphones in the United States. So educate people on that so they can educate others on that as well. So we're currently conducting a pilot randomized control trial with 40 individuals, all with a diagnosis. This is a larger sample. We're like, all right, well, let's see. Is this going to work with folks? So, and we're resubmitting a large grant with our team. So let me talk about some of just the future work, and then I can open it up for questions for folks. So other scientists on our team are working with recovery coaches who are peer support specialists who have opioid use disorders, working with service users in developing countries, and then caregivers of individuals as well. So here's our first study. We're actually integrating the PureTech technology in Norway. We're doing an adaptation process. On the left-hand side here, you can see who is part of our co-production team. This is just one of our projects being led by one of our colleagues as part of the team, Dr. Storm. We also have another project where we're integrating natural language processing. And what this means is that we're taking the text in text messages sent back and forth, and also audio from conversations back and forth, and we're using that to support the peer support specialist in delivering fidelity adherent interventions, meaning that they're delivering an evidence-based practice the way that it's supposed to be delivered, and also offering their expertise as well. And this is led by one of our colleagues, Mr. Kadia, as well. Another one of our technologies we're developing, in which there will also be a biosensor that's in development. Here we're working to identify neuropsychiatric disorders 10 years before they actually occur in an individual. And so that is dementia, Parkinson's, schizophrenia. So if we can identify it early, then we could potentially offer an intervention to offset disability progression. And this is an amazing collaboration between such a great group: payer systems, social workers, physicists, neurologists. Really exciting project. And then the biosensor is, what that means is that we'll be, yes, using a technology, but also using some kind of biological outcome, like blood or something like that, to confirm the actual diagnosis. And then another project we're leading up is called Supporting Older Adults Remotely. This is a project that is being led by myself and a colleague of mine in supporting older adults with serious mental illness. and to support them in community tenure, staying in the actual home. And then, I'm not sure if I missed it, but we also have a caregiver digital peer support app as well, where we're supporting, which is led by Ms. Collins Bassano, the PI, and she's working to develop an app for current caregivers with people with dementia. And then finally, we have a convening meeting around early mortality. That's all funded, where we're bringing together 40 people from across the world to develop the first ever patient-led research agenda around early mortality among people with serious mental illness. And I want to expand this to other disability states, and so that will be some future work. So people who maybe have multiple sclerosis or disability from autoimmune disorders. And so we're going to start with serious mental illness to work to develop this patient-centered research agenda to develop life-prolonging interventions. This is very exciting, and as you can see, we have so many people joining us from all over the world. And part of the process, this is one of our co-production teams. It's a pleasure to work with all the amazing people that we work with, and they've really pushed us to the edge of science, and we're always very open to collaborations. And so here I just want to thank the amazing people that we've worked with all over the world to make this happen. And as I say, this is just the beginning of the work that we're doing. We look forward to expanding and offering new trainings and dive into other types of disability states to help support people in their community and promote this equity of access for folks. So just want to thank everyone, and I am open for questions.
Carolyn, are you going to be reading the questions?
I can read the questions, sure. Let's see. Shiloh asks, is your organization working with projects or programs like Teledoc?
That is a very good question, and we're developing something different than Teledoc to support lay interventionists. And so what that means is people in the community who provide the mental health services. So we do have some work in that area that we are working on. But it's very different. And happy to share more if people want to reach out.
Thanks, Karen. Shuriken Jeanchart is very appreciative. She has no questions, but she says it's a lovely presentation.
Thank you so much. I appreciate that.
And Luke has a comment and a question. Engagement levels for any health intervention are influenced by a self-stoking spiral, comfort level to level of need. An acute level of need will motivate the user to reach for digital mental health intervention, even if the discomfort level of using that technology is high. Yet high levels of discomfort in using an intervention will discourage users unless their needs are acute. If the need is high enough, we will reach out even if we're uncomfortable to do so. Mental discomfort and distress in using digital mental health intervention is therefore an unfortunate irony, but it points to a hypothetical question. Could this mean that in your low engagement situation, current DMHI usage levels are actually identifying the section of users with the most urgent mental health needs?
Wow. That's fascinating. And it's a very interesting research question that if you had any interest in us studying that, just reach out because that question hasn't been answered. And I do wonder about that, because what happens in some of the commercially available products is that people download these apps and they use them like a gym membership. They go when they need to, so they may check in, once a month. If they're, and people have said to us that it's nice knowing that someone is there for them, and it's just on the app and they can engage at any time. And that's potentially the working well, who maybe don't have these acute mental health challenges. And so it's a fascinating research question, and if you have any interest and you want us to study it, just please reach out and we'll make that happen. It's an important question too.
Okay, Polaris Grayson asks, how has the socioeconomic differences in the demographic topography caused issues and barriers in the peer groups?
That's a great question as well. And we did not see any differences by racial and racial status in ownership of the technology, because likely that organizations actually provide the technology to individuals to provide the support services. Ownership outside of a trained workforce of peer support specialists indicates that scientifically that around 88% of people with a diagnosis of a serious mental illness own a smartphone, and that number is increasing. We have not seen racial differences. We have seen age-related differences. Older adults with this diagnosis own less technology. And what's really interesting is that we're seeing people are increasingly using this technology over time and having access to it because of programs that within the United States federal government and other places overseas have them as well, that provide people free access to smartphones. So there's SafeLink, Assurance, and in the State Assistive Technology Act, you can get access to potential robotics, assistive technologies. And then within this as well, there's something called Lifeline that gives people access to data plans as well at very low cost. And so I believe that is why we're seeing a lot of people with this diagnosis own these technologies and use these technologies every day.
Okay, thank you. Shiloh asked a question, can you describe a little bit on the difference? And Shiloh, your question kind of got out of sequence, so you might want to share a little bit about what you mean by difference, a little bit the difference on what. James Hartsong asks, does talking with others who have PTSD help us work through our PTSD, i.e. peer support?
That's a great question, and I'm really happy that it is asked. And so what's interesting is that when we talk about trauma, maybe we don't talk about the details of the trauma because we don't want to exacerbate another person and their experiences with that. And so if we talk about the overall trauma, not the actual details, there is a potential to support individuals. And some really great work coming out of the Veterans Administration is that playing your favorite video game, whatever video game it is, actually helps people with symptoms of PTSD, in that it probably likely distracts individuals. And so I do see an opportunity for video game peer support and sharing those types of peer support with other individuals through technologies would support people with challenges related to PTSD.
Charlotte wonders if programs like this could also have access provided at rural public libraries.
Yeah, there are, what is that actually? Well, I was thinking that people go to libraries and use the digital technologies, like they use their Wi-Fi signal. I'm not sure I'm understanding that question.
Building on a comment that Shella made earlier, she was wondering about the difference with teledoc, if you could talk a little bit more about the difference with teledoc.
Oh, unfortunately, I can't because it's part of a patent pending process. So unfortunately, I cannot talk about the difference. But if you send me an email, I'm happy to have a offline conversation about it.
Okay, Shella says, oh, okay. And Gentle says, thank you, Karen. Those are interesting projects. Audience, please click on the box by Dr. Fortuna's feet to get her notes from the presentation. And also, Gentle has a question. You're including a wide swath of people for your projects, not only from multiple countries, but multiple societal roles. How do you help scientists, for example, learn to communicate well with insurers or help patients find a voice with policymakers? I'm wondering if cross-role communication is perhaps more difficult than cross-country communication. I'm not asking about peer-to-peer communication because that training has been well established.
Yeah, that's a great question, and that's exactly what we do in these dyadic structures. So we have groups of scientists and policymakers and payer systems come together in patient populations, and they go through an experiential training with us in that we talk about experiences of cultural humility and sharing yourself and who you are and what experiences that you bring to the table. And together individuals develop research projects, and we integrate our accountability to multiple time points and address any challenges that arise around feelings of being well prepared and around potentially not being respected. And what's interesting is that there's all these trainings for the patient population and research, but there's nothing out there from what we have found for the actual scientists and policymakers in doing that. And so we hypothesize, and we're studying this, if we could provide the patients the voice and the advocacy to work with individuals, but also the scientists, helping them understand the humanistic values in the scientific method, in that listening to patient partners and ensuring people are respected and valued. And so I'm happy to share those results once we kick off our study, which is actually May 28th, which is very exciting. And then after people go into these dyads, they go into work groups and develop grant applications together and have that experience. And then we offer some technical assistance for folks around identifying the correct community engagement strategy for the population that you're working with.
Thanks, Karen. And also, Shala's made a comment just saying thank you for sharing your research.
Oh, thank you. Thank you for joining.
I'm just wondering if we have any more comments or questions for Karen. Slayton says, great presentation. Thank you. Roxy's applauding.
Great, thank you. Yeah, and please feel free to reach out. We're always we're very collaborative, and there's lots of things in the world we want to change, and so I'm happy to have future conversations.